We are live now.
Vinod, you're mute. Samira, yeah.
Yeah. Okay. So, hi, good afternoon, everyone, and a very warm welcome to all of you on this masterclass on corneal healing. Cornea is a unique structure, and maintaining and restoring its transparency after injury or disease is very important to all of us, to every ophthalmologist. So we thought we would have this on corneal healing. So Dr. Vinod Arora, he's an eminent and a pioneer refractive surgeon from Dehradun in the Uttarakhand province of state of India. He is president-elect of Intraocular Implant and Refractive Society India and past president, North Zone Ophthalmic Society. He's a great friend, and he's going to be our moderator for this session. He will also share his experience on how to improve corneal healing after refractive surgery later in the session. So over to you now, Dr. Vinod.
Yeah, thank you so much. Thank you, Dr. Samira, for arranging this beautiful seminar. I will share my screen first. So today we are going to have a seminar on corneal healing. Basically, we'll be looking for pathophysiology of corneal healing and causes of non-healing. We have got with us very wonderful speakers. Dr. Samira Irfan, you all know her very well. She is a consultant pediatric ophthalmologist, strabismologist, oculoplastic surgeon, ocular surface disease specialist at Lahore in Pakistan. She is an avid educationalist and researcher. She has 72 index publications. She has written 4 books on strabismus and oculoplasty and contributed to 9 book chapters. She is presently editor of SAO Chronicles, that is the official publication of SARC Association of Pediatric Ophthalmology and Strabismus. She is again editor of Indian Journal of Clinical and Investigation Ophthalmology. She is the vice president of Oculoplasty Society of South Asia. She has received gold medal for the best pediatric ophthalmologist in Pakistan in 2014. Again, she was conferred Excellence Award by SARC in 2018. She was conferred gold medal for excellence in ophthalmology in India in 2018. Again, gold medal for research and development in Pakistan at 2019. And she got the best editor award 2021 from IESR of India. I can't add all the points, but you know her very well. She is a topmost educationalist and researcher, doing all the contribution and teaching almost half of the globe. So Dr. Samira is going to speak on first pathophysiology of corneal healing. Second will be common cause of non-healing. I think just to save the time, I'll have the second speaker also with us, Dr. Quresh Muscati. He is one of the most respected eye surgeon of Indian continent. If you talk of SARC or any country, everybody knows him, and he is a multi-talented person. His contribution to various fields of ophthalmology is there. Dr. Quresh was president of AIOS, All India Ophthalmical Society, in 2014-15. He was president of Corneal Society of India 2017 to 19. He was president International Society for Manual Small Incision Cataract Surgery. He's got Lifetime Achievement Award for International Society for the Cornea and Keratofractive Surgery. He was conferred gold medal from IIRSI, the Intraocular Implant and Refractive Society of India, for his pioneer work in keratoprosthesis. Presently, he is chairman of SAPOSA, that is SARC Association of Pediatric Ophthalmology and Strabismus. So we have got very wonderful speaker with us. So without wasting time, I'll invite the speakers. Dr. Quresh Muscati is going to speak on ways to improve corneal healing. Over to you, Dr. Samira.
Thank you very much for a wonderful introduction and just your kind words. So I'll go to my talk. Okay, full screen. It's full screen now. Yeah, it's okay.
Yeah, it's not full screen yet, but it's okay.
On this, I can move my cursor. If
Yes, yes,
I
it's okay.
full, I won't be able to. It's okay?
Okay.
Right. So, pathophysiology of corneal healing. So first, I will tell you a little bit about the corneal structure. The cornea is exposed to extremes of environment all the time and is susceptible to injury and attack by bugs. To protect its structure and function, it has three important, powerful mechanisms. Number one, the eyelids, they just close like a shutter and immediately at the sight of danger and warn us of and keep us safe from any injury or a bug attack. Number two, a healthy, stable tear film that catches and washes away any foreign bug or debris that finds its way towards the ocular surface. And number three is that cornea has a powerful healing mechanism to repair itself. So if any of these three mechanisms are faulty, then corneal transparency is affected. So in any patient with the corneal non-healing defect, then we have to analyze which one out of these three mechanisms are at fault. So skin and cornea, they are both exposed structures all the time. All our body tissues are composed of 80% water, but they are protected by a covering of skin with the thick layer of keratin to prevent the absorption of water and a vast supply of blood vessels to maintain body's temperature in extremes of conditions. On the other hand, cornea is devoid of keratin and it has no blood vessels, so as to retain its transparency. So if its epithelium, moreover, is rapidly multiplying to replace any dried dead cells. Therefore, it has a high demand for oxygen, glucose, protein for its maintenance. And this demand is met with by the tear film. So the tear film not only polishes cornea and supplies it with oxygen and nutrients, it provides the most important growth factors for rapid regeneration of epithelium as well as the corneal nerves. And in addition, it prevents the bugs from attacking the cornea and washes away foreign bodies and debris, as I will show you in a minute. So the cornea is a 5-layered structure, and to retain its transparency, the corneal surface epithelium has a very important role to play. The surface epithelium is hydrophobic, and that is, it is water repellent, but at the same time, it needs the tear film to wet it and protect it and perform all the functions that I've just mentioned. So how is that brought about? So as demonstrated in this figure A, there are the brickwork. The corneal surface epithelium is like a brickwork with the surface cells. They are interdigitating like a wall, the brick in a wall, and they are joined together by tight junctions with a cement substance, which are called the zonular occlusions, which are on the surface, and they prevent any water from entering the corneal epithelium from the aqueous. So zonular occlusions on the top and these tight junctions in the side walls or of the surface epithelial cells, they prevent any water from entering the cornea and keep it transparent. Then the surface epithelial cells, they have another important feature of these microvilli and microplicae. These increase the surface area of the corneal surface epithelium, or which the tear film can stabilize. Now, as I mentioned that this is hydrophobic, so now to make it hydrophilic, these surface epithelial cells, they secrete this green blanket, which is the glycocalyx layer. It's a protein layer with carbohydrate side chains, and this glycocalyx layer is negatively charged. In the tear film is mucin, which is circulating as free mucin molecules, and they are positively charged. They are attracted towards these negatively charged glycocalyx layer. thus forming a mucin glycocalyx blanket. It's like a blanket that covers all these micro plicae and microvilli. And so over this blanket, the aqueous component of the tear film can stabilize and stay over the cornea and make it wet. Another important function of mucin is that it floats as free molecules, and as soon as a bug or a foreign body lands on the ocular surface, all these mucin molecules, they jump in to surround it. So the bug is is surrounded by the mucin molecules, and then there is increased production of aqueous, and this is washed out of the eye. And that bug has no chance of landing on the corneal epithelial cells and to produce disease. So this is a very powerful mechanism. As long as the tear film is healthy, no bacteria, virus, or fungus can attack the cornea and produce disease. And since the tear film is constantly exposed to the atmosphere, as soon as it evaporates and a dry spot appears, then that dry spot leads to stimulation of the nerve endings, supplying that nerve cell, that epithelial cell, and immediately all three components of the tear film are produced. And this is by virtue of this lacrimal functional unit. And this is by virtue of, again, a rich supply of nerve endings to the cornea. There are about 2 million naked nerve endings, which are supplying the cornea in the form of three plexuses: the intrastromal plexus, the subbasal, and the intraepithelial plexus. So every corneal surface epithelial cell is supplied by a nerve ending, and as soon as there is drying or there is loss of one epithelial cell, that triggers the strong functioning of the lacrimal functional unit, and the tear film is replaced, and the bacteria or whatever is washed off, and disease is not produced. So what happens if these corneal nerve endings are cut? As in during cataract surgery or in corneal graft or in LASIK, then these nerves, they take a long time to regenerate. And also nerve endings are gone. And at the same time, there is mucin glycocalyx layer is lost at the site of injury, at the site of a scar, and tear instability stays for weeks. So this is the time where bugs can easily attack such an eye. So it's very important to prescribe lubricants and prophylactic therapy to these patients, because the tear film is unstable at that stage, and that corneal surface is vulnerable to disease. And so neurotrophic keratitis, an important condition, and this can happen when there is corneal hypoesthesia and there is loss of tear film, loss of growth factors, and blinking. So the nerve plexuses, they can be destroyed most commonly by herpes and by adenoviral keratitis. Just a sec, I'll turn off my phone. So, and in chronic dry eyes, there is loss of these nerve fibers, loss of the nerve growth factor, and the healing capability of such a cornea is reduced. Then in diabetes, a very common cause of neurotrophic keratitis. In diabetes, there is autonomic neuropathy, and there is loss of tear film as well. So again, vitamin A deficiency. Then in injury or corneal ulcer, there is scarring. Chronic contact lens wear lead to disruption of the tear film, which I'll show you in a minute. Chemical burns and use of topical beta blockers, anesthetic drugs, or NSAID also not only lead to tear film instability, but they dampen the signals transmitted by the corneal nerves and produce corneal anesthesia as well. So now, what is the significance of these basal epithelium? The most important layer of this corneal 5-layer structure is the basal epithelium. And they are important for the repair and regeneration. As soon as there is a single cell lost, the basal epithelial cell, they multiply and they replenish that cell that is lost because of drying or desiccation. Then these basal cells, they secrete this basal lamina, which is in blue. And this basal lamina in turn is resting on the Bowman's membrane. Basal lamina is important as it is responsible for releasing growth factors and for forming a site of where the growth factors can act in case of stromal loss, or where there is loss of epithelium as well as stroma and injury. And then underneath the basement membrane is the Bowman's layer. And this Bowman's layer, this is the strongest layer of the corneal epithelium. And once Bowman's layer is lost, it cannot regenerate. It is replaced by scar tissue. So the basal epithelium is firmly adherent to the underlying stroma by these peg-like structures, these yellow lines. And these pegs, these are microfibrils, and they adhere the epithelium strongly to the underlying basement membrane, the Bowman's layer, and the stroma. And the whole unit, this functions as a single unit. But if these fibrils, these microfibrils, they are damaged, they are not produced, as in cases of injury, epithelium is replaced in about 24 to 36 hours. But these microfibrils, these pegs, they take at least 6 weeks to fully function, fully form. And in those 6 weeks after injury, even though the epithelium has been there, but in the absence of these microfibrils, this epithelium is very friable, fragile, and that's what happens in recurrent corneal erosions. And recurrent corneal erosions, they heal in about 24 hours or 36 hours, but these microfibrils are not there. So while a person is asleep, there is the tear film absorbs, and there is hypoxia inside the eye. As soon as a person opens up the eyes in the morning, the hypoxia and the lack of tear film, it again breaks up these epithelium at the site of injury, and that epithelium, which is friable, it just splits up in the absence of these microfibrils. This happens almost every day, so that there is an attempt by the basal cells to replace the basement membrane, but that basement membrane is abnormal. Because in the absence of microfibrils, that abnormal basement membrane material just floats about in the surface epithelium, and the epithelial cells which are regenerating from these basal cells, they are trapped amongst this basement membrane material, and they form a cyst. And number one, the epithelium is friable, and number two, there are cyst formation. So Dr. Quraish is going to tell you the treatment, but that's what's happening every other day. And these erosions, it's a painful condition and a real problem for the patient and for the clinician as well to deal with them. So coming on to the next is the stroma, the very important stroma. It constitutes the main thickness of the cornea, and it is about 500 micrometer thick. And it is an organized network of collagen with extracellular ground substance. And they are arranged they are linked and cross-linked all these collagen networks so that they form a lattice arrangement, which is very regular with regular spacing, and this is responsible for the corneal transparency. But when there is a deep injury which involves the stroma and new fibers are formed, these newly laid collagen fibrils, they are running around in every direction. And that's why the newly laid corneal stroma is never transparent, but it is opaque. Gradually, over a period of 6 months or a year or even 3 years, the corneal cross-linking occurs, and then the transparency is restored. So underneath the stroma is this Dua's layer, which was discovered recently by Professor Harminder Dua. And this wasn't there before, and it is a collection or aggregation of fine collagen, which is present at the end of stroma and where the Descemet's membrane is. So it is between the Descemet's membrane and the stroma, and Descemet's membrane is actually the basement membrane of the corneal endothelium. It is the toughest membrane, that remains even after all the stroma has melted. And underneath is the endothelium, which is a single layer of hexagonal cells. These cells, they're about 2,000 to 3,000 per cubic millimeter, and they don't have the tendency to replicate. If there is loss of one endothelial cell, the adjacent endothelial cells, they flatten out to fill up this gap. And if this, when the stroma is melted, this tough layer, the Duas membrane, the Decimus membrane, and the endothelium, it just protrudes out when there is stromal melting, and this constitutes the decimetocele. So decimetocele is actually a combination of these two membranes and one endothelium, which is lining this. So now coming on to corneal healing, how does the corneal healing occur? Now, normally there is the XYZ hypothesis, which explains the daily loss of surface epithelial cells from the surface in response to drying, and they are lost in this Z vector into the tear film. And then there are the basal cells which are dividing. One basal cell divides into two, and then it in a Y vector, it moves upwards to replenish the surface epithelial cell which has been lost. So this happens daily, and no corneal erosion or epithelial defects are produced, because our tear film, if the tear film is healthy, the growth factors are there, and this cycle, it continues. And the surface epithelium, the whole of surface epithelium can be replaced in about 1 week, provided the tear film is there to replenish all the growth factors, the nerve supply is there, and everything is fine, then the whole epithelium can be regenerated. When the demand for this epithelium, surface epithelium increases, then these limbal stem cells, which are situated in these crypts of Vogt, are called upon. And these limbal stem cells, they divide, and one stem cell divides into two. One cell, daughter cell, stays here, while the other moves along the x-axis and goes to replenish the basal cell, and then that basal cell moves along the Y vector to replace the surface epithelial cells. So this movement of cells from the limbal epithelial crypts, it continues centripetally and along this x-axis. So X, Y, and Z is the lost epithelial cells. So this is the normal process that's occurring whole day, every day, 24/7. So, and these limbal stem cells, they are crucial for corneal healing, as I've just mentioned. They form a barrier between the corneal epithelium as well as the conjunctival epithelium. So there's conjunctival epithelium on one side, which is stratified columnar, and there is this stratified squamous surface epithelium of the cornea. And these limbal stem cells, they form a strong barrier. They prevent the conjunctival epithelium to grow over the corneal epithelium. This happens when, if the limbal stem cells are lost in the conjunctival epithelium, it grows over the cornea, and then this is visible as opaque cells. And another important function of the limbal stem cells is to maintain corneal transparency and prevent corneal vascularization. So the corneal vessels are stopped short of the limbus, and they are prevented from moving on over to the cornea and to retain corneal transparency. And for their health, they require an adequate tear film, control of inflammation, and avoid any mechanical damage. So now let's see what is the sequence of events in an abrasion. In an abrasion, there is a large epithelial defect, but without an infiltrate. So without an infiltrate means that it's a clear-cut margin, but it's a large area of epithelial loss. And this has to be distinguished from an ulcer, which is an epithelial defect, but there is an infiltrate. Infiltrate means there is pus formation, there are microbes there. So the healing process in these two is quite different. So when there is only an abrasion, then there is the epithelial phase, in which within 4 to 6 hours, there are changes in the epithelium adjacent to the area of epithelial loss, these epithelial cells, they lose their tight junctions, hemidesmosomes, and they flatten and they develop phylopod extensions, and they try to move in to cover this epithelial defect. So the defect is covered over in 24 to 36 hours. So these cells, they migrate. For this migration to occur, there should be the appearance of the laying down of this matrix substance, the fibronectin, which is like an anchor. It's like one person helping the other one to climb a mountain. So these anchors, they are thrown into the fibronectin, and then one cell, it holds the hand of the other cell, the phylopod of the other cell, and pulls them towards the center of the epithelial defect, till whole of the epithelial defect is covered by a single layer of epithelium. And then once this single layer of epithelium has covered the defect, then cell proliferation starts, borrowing the cells from the limbus and in an X vector, and then in the Y vector, they replace all the cells lost, and the corneal epithelium, the whole thickness of the corneal epithelium is achieved. So what are the sequence of events in an ulcer? In an ulcer, there is infection and there is polymorphonuclear infiltration. They are called upon from the blood vessels. An ulcer will only occur if there is a damaged corneal surface or the host resistance is decreased, and the bugs, which are the normal commensals of the ocular surface in the conjunctiva or the eyelashes, they then invade that area of damaged corneal surface and produce an ulcer. So there is an injury and there is dilatation of vessels. Polys, they migrate to the area and they kill the cells, the epithelial cells. So this killing, this forms pus and debris. And as long as this infection is not controlled by appropriate therapy, the killing continues, more pus is formed, more debris is formed. And the second stage cannot happen unless this first stage inflammation is controlled. And once the inflammation is controlled by appropriate therapy, then the second stage of removal of debris and dead cells starts as the macrophages, they infiltrate the area, they remove all the necrotic material so that there is a clean cut, clear area over which healing process can start, the third stage of healing can start. So first stage, most important in corneal ulcer healing, is to control the inflammation so that the second and third stages can happen. But unless the first stage is controlled, the inflammation continues and the ulcer then becomes a progressive ulcer with a non-healing defect. So 4 stages of an ulcer, it's progressive infiltration, then active ulceration, and then if the antibiotic and all the treatment is working at that time, is adequate, then the stage of regression and cicatrization occurs. Then stromal healing, the factors which are required for healing of the stroma is that the epithelial blanket has to be first formed. Once the epithelial layer has laid down, only then stromal healing starts. And that occurs in the presence of these growth factors, which are derived from the epithelial cells, from the nerve endings which are supplying here, and from the fibroblasts which are activated once the epithelium is lost and there is breakage of Bowman's membrane. So these are growth factors as well as insulin. And why is insulin required? Because all this mechanism, this active multiplication requires glucose and glycogen breakdown and energy, for which insulin is a must, as well as vitamin A. So in diabetics, this healing is very much delayed. So stromal healing involves a complex interaction between epithelium, keratocytes, tear film, growth factors, and corneal nerves. If one of them is not there or functioning properly, then stromal healing is affected, and fully healed epithelial basement membrane releases growth factors, which then activate keratocytes to become fibroblasts. So fibroblasts then lay down the collagen, which is at first disorganized, and later, once the epithelium has healed, once the basement membrane and the Bowman's membrane has formed, then the keratocytes, they change, and the haze, corneal haze, it stops clearing. It starts to clear up. So as long as the epithelium is damaged and the Bowman's layer is damaged, then these growth factors, they keep on entering the stroma, and this metallic matrix metalloproteinases, they keep on accumulating, activating the keratocytes to become fibroblasts, and they continue to lay down the extracellular matrix. And that is mainly responsible for this corneal haze, which is apparent after injury. And once the epithelium is healed and the basement membrane is laid down, then the further ingress of these growth factors and metalloproteinases or the collagenases, this is stopped. Further breaking down of collagen is stopped, and the laying down of matrix stops, and the collagen network, it arranges as a lattice network. So important factors that need to be considered in a non-healing ulcer is failure to control inflammation, that is failure by the clinician to identify the cause or institute appropriate therapy in proper dosage or proper. Usually clinicians, they are in the habit of giving a cocktail of antifungal, antiviral, antibacterial, and they all cause toxicity of the limbal stem cells as well as the epithelium, which is healthy adjacent to the ulcer. So all this cocktail causes more toxicity than any good. So it has to be appropriate therapy. Preservatives, they also cause a lot of toxicity. And then another important cause is lack of growth factors, which is in the absence of a healthy tear film, in the when there is the poor general health of the patient, especially diabetes, and the cornea is neurotrophic. So limbal stem cell deficiency, it is, you can assess clinically if there is conjunctivalization of the cornea with thick irregular epithelium, if there is secondary the pannus formation, and there is fluorescein pooling because it is thin, epithelium is thin, and there is inflammatory cell infiltration, and causes are multiple, congenital or acquired, and these must be corrected. So Dr. Quresh will go into it, how to correct this. And a persistent epithelial defect, an epithelial defect fails to heal if there is lack of growth factors, lack of the matrix substance, the fibronectin, over which the epithelium can grow, and there's continued inflammation, and the cornea is again neurotrophic. So there is rounding of edges of the epithelial defect, and there is rim of loose epithelium, and the stroma is diffusely hazy. And that's how you diagnose a persistent epithelial defect. And contact lenses, they are a major cause of tear film instability. And if the person who is coming with a corneal ulcer has been wearing contact lenses, then obviously that cornea has, the tear film is highly deficient. It is a hypoxic cornea. And also there is mechanical damage to the limbus and loss of limbal stem cells in such a patient. And another important cause of continued inflammation in a corneal ulcer is a constant supply of microbes. If the clinician has failed to identify blepharitis, meibomian gland dysfunction, or infection in the lacrimal sac, or the organisms are of very low virulence like Moraxella, mycobacteria, which need special kind of antibiotics. So these need to be kept in mind. Incomplete blinking is another cause in which there is failure of the pump function, and the spread of tear film is faulty over the cornea, and therefore the cornea is not supplied with an adequate supply of growth factors. So, and every patient coming to the end, you have to assess the stability of the tear film in a non-healing ulcer or a non-healing epithelial defect. You need to find out and treat the source of constant supply of bugs. You need to find out whether the corneal sensations are there or not. You have to correct the exposure, corneal exposure, if there is faulty blinking. So in summary, the epithelial healing, it starts immediately and completes in 24 to 48 hours. But basement membrane and its adhesion complexes, they take 6 weeks to form. So in that 6 weeks, you need to prevent damage to the healed epithelium. Stromal healing, it starts in 2 to 3 days, but thick scar, it takes 6 months to form. And remodeling of the scar takes another 3 years. And for all of this, tear film, growth factors, corneal nerves are mandatory. So thank you very much.
Thank you, Dr. Samira, for such a wonderful talk. It was very, very illustrative. And before we jump to second talk, I see any question there. There's one question. What is the role of Bowman's membrane?
Bowman's membrane is there to stabilize the epithelium. As I mentioned, there are fibrils going from the basement membrane of the basal cells to the Bowman's membrane and then on to the stroma. So as long as Bowman's membrane is there, the epithelium will heal without a scar, with like a nebula or a macula. It will not form a thick scar as long as Bowman's membrane is there. But once Bowman's membrane is disrupted, then there is a permanent scar. So Bowman's membrane is very important.
Can I add? I'd like to think of the Bowman's membrane as the roof of the stroma and the basement membrane as the floor of the epithelial layer. So you need the roof and the floor. If there is only the floor and the roof is leaking, you're going to land up with a problem. So the entire epithelial layer has to be supported by a strong roof of the stroma. So the stromal roof is the basement, is the Bowman's membrane.
Absolutely.
In advanced surface ablation, we take out the basement membrane and we have to use special measures to avoid scarring. I think that's very, very important. And we have got another question. In corneal abrasion, what you advise, patch eye or use contact lens?
I patch eye personally, because if there is no infiltrate, so the epithelium will heal in 24 hours. So all you need is that the patient should not blink in those 24 hours. But after the abrasion has healed for 1 month or at least 6 weeks, as I said, the fibrils, microfibrils are forming, the hemidesmosomes are forming. So you have to give lubricant to the patient at night and during the day as well for 6 weeks after injury. But I don't give contact lens because it's a foreign body. So I personally, I don't.
There have been umpteen papers now published on this, to patch or not to patch a corneal abrasion. But see, it all depends on the situation you are in and the type of practice that you have. If you have the slightest doubt that there could be an infection, for example, if this patient has fallen into a gutter in a drunken stupor and he has come out and you examined him and you feel there is no infection, there is just a corneal abrasion, I would be hesitant to patch this patient because there's a possibility that you've missed an infection which will come up later. So under the patch for 24 hours, those bugs could fester. So simple rule is, if you've got any doubt that this could be infected or can get infected, don't patch. Leave it open on lubricants and it will still heal. As Dr. Samira eloquently explained, the sliding mechanism which the epithelium undergoes as the first line of defense, in a few hours' time, it has slid over to cover the defect at least with a single layer, and then the XYZ thing kicks in. So it's going to heal in spite of the not patching. It may take a little longer because our lids open and close, and they tend to knock off whatever epithelium is coming in the way, but it will heal. But if you think it's very clean and you want to leave it open, you can leave it open with a contact lens or even without a contact lens, but with hourly lubricants. So it depends on the situation and the patient.
So we got good number of questions, but I think that we can take after the talks. Otherwise, the talks will be delayed. And I request Dr. Quresh Muscati to take over. Dr. Quresh, sir.
Thank you. So we're going to talk about take off from where Dr. Samira ended, which is she told us about the normal physiological healing of the epithelium and the stroma and what happens in pathology. Now let us see if we can do something to improve the corneal healing. We'll just start with the first slide. Just give me a minute. Yeah, are my slides visible now?
Sir. Yes,
Yeah.
sir.
So what are the steps that we can take to improve the healing process to help Mother Nature? Let us see what we can. So I've just taken at random a few things. We know the goals of treatment as said by Dr. Samira to promote reepithelialization. And there is a secondary goal, which is relief of pain and discomfort, because the patient is not interested in reepithelialization. He doesn't understand these big words. He wants relief of pain and discomfort, which is there. So can we do both the things? We need to look after the secondary goal as well. Just because we are very academic and we are doing the best we can for reepithelialization, and you don't give them a painkiller or something like that, he's going to be miserable and move on to Dr. B, C, and D in search of more sympathetic doctors. So let's go on to one by one. Topical vitamin C. Now, vitamin C is easily made. You need 10% vitamin C. It's useful for all non-healing defects, especially in chemical burns. Why especially in chemical burns? Because in chemical burns, it's been found that by studying the aqueous humor, that the vitamin C is almost near zero in these patients. So why do we require? Because vitamin C is required by the fibroblasts to make collagen. Dr. Samira told you about how the fibroblasts make collagen, lay down collagen. And then there are these nasty bad guys called the collagenase enzymes, which break down this newly formed collagen. So what happens? The vitamin C comes in and not only pushes the fibroblasts to make collagen, but it also acts as a guard, like a fencing around the newly put tree. You know, like you put a tree there, there's a fence around to prevent the collagenases from breaking the newly formed collagen. And it's such a cheap substance which is available all over the world. You typically get vitamin C as injections. In most countries, you get 10% sodium ascorbate or 500 milligrams in 5 cc. This is available everywhere. You simply have to break it, put it in an empty lubricant eye drop bottle, just remove the eye drops from an empty sterile 10 ml bottle and inject this vitamin C. So no dilution is required, no concentration is required. You don't have to think too much. It is already 10%, which is what you need. And way back in 1991, Pfizer et al. in IOBS, in ARPO had come out with this. Even way back in 76, 77, 80, there are articles of this. So we need to get into the habit of using vitamin C more often for healing. Number two, again, something very simple. I'm starting from simple to the more complex, something called autohemotherapy. That is use of the patient's own venous blood. So patient's blood is available to you. You simply puncture the antecubital vein in the elbow, remove 1 to 2 cc of the blood, inject it subconjunctivally in a patient with chemical burns. So when you inject subconjunctivally, as you can see over here, it's like having a subconjunctival hemorrhage. So the growth factors which are in the blood is rich in growth factors and many other things which I will explain a little in a minute. So you can inject subconjunctivally on alternate days or once in 3 days if the patient is admitted. So you can, second thing is if the patient is admitted at night, you can take the same antecubital venous blood and put a drop on the cornea, again put another drop, keep putting drops with a speculum in or your fingers holding the lids apart till you get a blood clot formed on the cornea. Then gently pull the upper lid down and close the eyes so that and patch the eye at night. So this blood clot also contributes a lot of healing factors at night, and during the day the subconjunctival blood takes over. You can also use autologous serum 20 to 50% as eye drops. I'll talk about autologous serum later, but these are 3 uses of blood, especially in chemical burns. So what is the use of the role of blood? It acts as a buffer, it dilutes the chemical, it separates the tissues, it acts as a barrier against further penetration, and it's fibrinolytic, so it prevents symblepharon formation. It also contains anti-proteases, which inhibits collagenase. I told you about as the poor fibroblast is trying to lay down collagen, and these bad guys, these evil guys, these villains in our movies, they are the collagenase which keeps trying to break it down. So the blood contains anti-proteases or anti-collagenases. So it prevents the collagen from breaking down. And our platelets, now if you remember your MBBS days, the platelets were like oval in shape or cuboidal in shape. Now these become pseudopodal in shape. They grow pseudopods like an amoeba, and they go and adhere, they go and hold on to the collagen, just like the dog and the cat in the picture. They hold very tightly to the collagen and prevent it from breaking down. So there is so much of role of an easily available substance called the patient's own blood. Moving on to the third one, which is autologous serum drops. Why do autologous serum drops work? First of all, how do we prepare autologous serum drops and what is the concentration? Well, people have used right from 20% concentration to even 100% concentration, but most people prefer between 20 and 50% concentration. So it's very easy to prepare. Most laboratories, blood laboratories will prepare it for you. All that you have to do is to allow the cells in the blood to settle down, or you can centrifuge and let the cells settle down. And the material, the supernatant material without any cells, is the serum. And then you can dilute the serum using artificial tear drops. And if you dilute 1:4, 1 ml of the serum and 4 ml of either distilled water or the artificial lubricants, you will get 1 in 5, or that's 20% serum drops. So autologous serum drops. Why do these work? They work wonderfully in non-healing ulcers, non-healing defects. It could be that the density of the serum drops, the fact that they have a lot of albumin, it could be coating the eye and driving the beneficial effects. It forms a layer immediately, almost like a bandage contact lens. Also, serum contains bioactive agents that may promote healthy cell growth and healing of the surface. It includes antibodies, it's rich in vitamin A, and the nerve and the epidermal growth factors that Dr. Samira talked about. The serum is rich in that. Our tears is rich in that. Serum is rich in that. So if you don't have autologous serum or you want to use something fancy, then there are other things which are serum substitutes. So this is the fourth thing we're talking about. Allogenic serum, umbilical cord serum. People have used amniotic fluid drops. Then there is now a lot of interest in platelet-rich plasma. So it's not the serum alone, but the platelets are taken, because I told you about how platelets are also useful. And then you have plasma rich in growth factors, and nerve growth factor itself has been, they've isolated and they're using it, something called oxynervin has been investigated, but these are not mainstream therapy. The nerve growth factor is a little mainstream, mainly in Europe and parts of the US, but extremely expensive. The cost for a treatment of a neurotrophic keratitis goes to something like 8,000 euros for a patient, which is not affordable to almost anybody in our subcontinent. Number 5, oxygen therapy. Again, something as simple as oxygen. Of course, in our country as of now, oxygen is a big talking point because of COVID, and because COVID patients require it and it's not available, and there is a lot of politics going on over oxygen. But in the good old days and in the days, good new days, which will come following COVID, I'm sure, we will have spare oxygen to use with speed of healing of epithelial defects. A lot of work in this has been done in Iran. And they have found that a study which took 24 eyes with grade 3 to grade 4 acute burns. And they found if they divided into those who received 100% oxygen therapy using a simple mask, as you can see in the picture above, at a flow rate which is moderate, 10 liters per minute for just 1 hour twice daily, they found that the epithelial defects healed faster in the oxygen group, 15 days versus 60 days. And the vascularization of ischemic areas also improved. So it increased corneal transparency, decreased corneal vascularization. So in Iran, there's a lot of use of this. Some of this has not yet hit the mainstream. Then there are various other measures which we can employ, and I've just listed them, but we'll talk about all of these. Punctum and lacrimal plugs, the role of tarsorrhaphy, injection of Botox into levator, surgical tarsorrhaphies, Gunderson's flaps, amniotic membrane, scleral lenses, cyanoacrylate glue, mucous membrane grafts in lid viper epitheliopathy in Steven Johnson, and simple limbal epithelial transplant in non-acute chemical burns. So let's go through these one by one as time permits. So lacrimal plugs. Now, what is the role of lacrimal plugs in a non-healing defect or in an ulcer? See, we want to retain the tears in the eye for long. If the patient's tears are good, We want those tears because they are so rich in growth factors and in so many, they have so many antimicrobial effects. So we want to retain this. How do we do this? We can use collagen plugs. These are available for temporary blockage of one or both canaliculi. Suppose you don't have collagen plugs in your country. You can use chromic catgut, just cut chromic catgut into tiny pieces and stuff multiple pieces into the canaliculi. They will usually remain for about 8 to 10 days easily. In the meantime, your antimicrobial therapy will remain in the eye longer and it will help the patient. Also in India, we get what is called 90-day plugs, which are used by many refractive surgeons who want to promote the temporary drop in the tears which occurs following refractive surgery. So for 90 days, those plugs remain in place and then they dissolve. And of course, if the patient has an aqueous deficient dry eye, and suppose you're considering permanent plugs, it's good to use temporary plugs of collagen first. If the patient feels a wow effect at that time, then you can insert permanent plugs after a couple of weeks. So you can see the picture above, that's the permanent plug being inserted into the lacrimal punctum, lower punctum. There are two types of plugs. One is called the lacrimal plugs, like the one which I've shown over here. I have no commercial or financial interest. These are the Herrick lacrimal plugs. They are on a stillet. The soft silicone plug at the bottom and the metal tip comes out. So you just push it into the lacrimal punctum and turn it 90 degrees so that it goes into the horizontal part of the lacrimal passage and then leave it in place. So it remains inside the lacrimal passage and the flower-like thing on the top prevents it from extruding. So these are lacrimal plugs. You also get punctum plugs which sit on the punctum. Advantage being that you can see the plug all the time. But the Herrick lacrimal plugs now come with a with an opaque tip. So if you shine a naked bulb under the lower lid or upper lid, you can actually see it glowing. Tarsorrhaphy number 8 is a much neglected measure. Whenever there is non-healing, and as Dr. Samira showed you the picture of the patient whose eye was not closing well, even if the eye is closing well, but his blink action is low, then the patients who are not healing, if you can do a temporary closure of the lids, not a permanent closure, not the whole eye, but just a lateral 1/3 or half tarsorrhaphy. You can even do a tape tarsorrhaphy, just take a scotch tape and close the lids. Or you can use a drop of cyanoacrylate glue. It's a little bit of an overkill if you ask me, but just a single drop so that it makes sure it doesn't touch the conjunctiva or the cornea because it scars very easily there. So it becomes excessive. But just a drop between the two lids can stick the lids quite easily for about 3 months. You can, of course, do a surgical tarsorrhaphy, which is not difficult to learn. I would urge all of you to learn how to do a good, clean surgical tarsorrhaphy, which can be opened so easily by just putting an artery forceps and clamping the space between. And then with a scissor, you can cut it open. All can be done as office procedure in the consulting as well. And of course, if you want to charge the patient more, you can inject Botox into the levator. So the eyelid will droop. Here you can see the patient with the Botox-induced ptosis, so that the lid will droop and cover the eye and allow healing to take place. Then there are conjunctival flaps which you can use. So you see on the top is a partial conjunctival flap. So if there is a peripheral ulcer which is not healing, you can pull a conjunctival flap and just a partial flap should be sufficient. And it usually retracts over time, but by that time, at least you will have prevented a perforation and your antimicrobials will have acted. Suppose there is the limbal stem cell deficiency and there is the ischemia in that area, then to bring in blood vessels over there, you can do what is called a pedicle flap. As you can see in the second picture, that's a pedicle flap which includes tenons, which has got blood supply. And you bring it there to heal that the non-healing defect in the presence of limbal stem cell deficiency. And of course, if there is no other choice, if it's for example, there's a fungal corneal ulcer, and in spite of your antifungal measures, the ulcer is not healing, and you don't have therapeutic cornea available, many countries don't have it on demand, then you can pull a complete flap called a Gunderson flap or a total conjunctivoplasty to cover that fungal ulcer so as to prevent it from perforation and then continue antifungals. And maybe 6 months down the line, if all is well, you can do a penetrating keratoplasty as an optical measure instead of doing 2 keratoplasties. So this is a video of a conjunctivoplasty, not done for a fungal ulcer, but this was done for a painful blind eye, but the procedure is the same. So I'll just show you what it is. You first scrape off. This is the patient who's had a painful blind eye, previous trabeculectomy done. I ballooned up the conjunctiva using local anesthesia, and I've separated the conjunctiva on all sides. I am removing the tenons and subconjunctival tissue. So you need a good assistant to lift the conjunctiva up while you remove the tenons and subconjunctival tissue, taking care not to cut the orbital septum, otherwise you'll get ptosis. So I'm cutting it off. So again, this assistant drops the conjunctiva and picks it up at 2 other places. My assistant is experienced, he's using a LIMS forceps, but for those starting it, they should use non-toothed forceps so that you don't tear the conjunctiva. And you go around again 360 degrees. You see how thin the conjunctiva is becoming now, because and I've gone once and I'm going a second time round. So I'm able to remove much of the subconjunctival. So it's very, very thin now. And I'm using 6-0 polyglactin sutures to anchor it to the sclera on both sides, and then 8-0 polyglactin or vicryl sutures mattress to close the conjunctiva. And this conjunctiva is translucent. Patient can get even 6x60 vision through this conjunctiva. And many times after 6 months or a year, when my patient goes to someone else, they don't even know. They said this is a vascularized cornea. They don't realize that there is a thin layer of conjunctiva on top. And you can do a corneal graft through this even later. Then there is the amniotic membrane graft. Amniotic membrane, there are 2 types, the wet and the dry. We prefer the wet membrane if it's possible. If you can get hold of wet membrane, so much the better. We use the only from cesarean section deliveries. Amniotic membrane is not something new. It came out in the 40s and 50s, but it was given up because they were taking it from natural vaginal deliveries. And then the chances of infection through the vaginal passages was very high. So they used to lose the corneas because of infection. So we now take it under sterile conditions from cesarean section so that the placenta can be handled well in a sterile manner. The mother is tested for HIV/AIDS, and if she is negative, then we store it in Dulbeco's modified medium at -80 degrees. And after 3 to 6 months, we retest the mother again. And if she is still negative, means she was not in the window period of delivery, then the amniotic membrane can be used. It's stored on nitrocellulose paper, which is a special paper. There is a sticky surface and an epithelial surface. The sticky surface is the stromal surface that is stuck on the nitrocellulose paper. It sticks by itself, no glue is required. And the epithelial side is on the top of the paper. And you also have freeze-dried membranes, which are good for tectonic support. But if given a choice, you would prefer the wet amniotic membrane. Now, these can be used. Previously, we were using it only in old chemical burns, more than 6 months old. But in the turn of the century, in July 2000, we had the first paper in the American Journal of Ophthalmology from the L.V. Prasad Institute, Dr. Sridhar, who is no more, Dr. Rao and Dr. Sangwan. And they found that you could use it even in acute chemical burns. So this is the picture that I'm putting the amniotic membrane in acute chemical burns. So you thorough lavage and removal of the necrotic material, you can cover the entire affected area because it has a big anti-inflammatory role. It gets absorbed very fast, unlike in old chemical burns. This gets absorbed in a few days to a week, depending on the extent of inflammation. But in that time, it has damped down the inflammation considerably. How does amniotic membrane work? It suppresses apoptosis. Apoptosis is premature cell death of epithelial cells and promotes apoptosis of inflammatory cells. So for those of you who are from the Indian and Pakistan subcontinent and used to our Hindi movies, it kills the villains of the piece, the bad guys, the inflammatory cells, and prevents it allows the good guys, the epithelial cells, to live longer. So it suppresses apoptosis of the good guys, the epithelial cells, and promotes apoptosis of the inflammatory cells. More importantly, it enhances typical cell differentiation. Now, Dr. Samira told you about how the limbal stem cells acted as a barrier for conjunctivalization of the cornea. So conjunctiva stopped at the limbus. Now, in chemical burns, that barrier is gone because the stem cells are deficient. So now there is nothing to prevent the conjunctiva from coming there. If you put amniotic membrane, there are some things in the amniotic membrane, we won't go into details, which makes the conjunctiva remain as conjunctiva and corneal cells remain as corneal cells. It also enhances the epithelial cells attachments with each other. Dr. Samira again told you about the attachments, the side attachments which are there, the zonular occludents which are there between the epithelial cells. So they attach, and also they grow fibrils to attach to the amniotic membrane as well. And the amniotic basement membrane facilitates migration and growth of the epithelial cells, so promotes epithelialization. So there's a lot of things. Besides, since it's put over the limbal area as well, it alters for the good the stromal microenvironment and favoring epithelial cell migration. So the stroma, the microenvironment becomes less toxic, so it allows the epithelium to migrate over. And Dr. Samira told you that unless you have a good layer of epithelium, the stromal healing doesn't take place. So there are multiple uses of amniotic membrane. It's also anti-angiogenic. The avascular stroma of the amniotic membrane reduces fibrovascular ingrowth and abnormal neovascularization. It is anti-scarring. It facilitates nerve regrowth. It has mild antimicrobial effects. At the very least, it acts as a bandage contact lens, especially the dry one, because it doesn't contain all these growth factors. And the epithelium produces anti-inflammatory and growth factors. So multiple uses of reasons why the amniotic membrane should be tried in every patient of chemical burns. Number 11 is the scleral lens prosthetic device in neurotrophic keratitis. What is the scleral lens prosthetic device has got multiple names. One of them is BSLPD, Boston Scleral Lens Prosthetic Device. It is also called, it was first called the Boston Scleral Lens. So it's gone through many name changes, but basically, if you imagine a teacup and a tea saucer. So the tea saucer is the Boston Scleral Lens. It has got a base which is shallowed out or deepened out rather, in which you can fill in normal saline. So you fill in normal saline in that large tea saucer, and then that whole saucer is put into the eye, so that the saline bathes the cornea, and the no part of the scleral contact lens touches the cornea. So it doesn't harm the cornea, doesn't touch the cornea, and the saline bathes the cornea. So it's got very high oxygen permeability, so that it allows sufficient oxygen to go into the eye, no contact with the cornea, and it can be customized to fit an individual's eye shape. Problem is the cost. The original Boston scleral lenses are about $1,500 US dollars each eye. But this is the neurotrophic cornea. You can see on my left the large amount of stain, and then after putting the scleral lens, the staining is much reducing, and the cornea is showing signs of healing. The whirl pattern that you see is signs of healing. Then cyanoacrylate glue. Again, for those countries who have access, it's not very expensive. In India, it's about $2 US dollars for a tube of cyanoacrylate glue. For small perforations which are less than 2.5 millimeters in diameter, and in impending perforations like desmetaseals, you can just put a drop of this. The important trick is not to use too much. You see in the picture below, the surgeon has used too much, so there is a lot of glue on the cornea, and there is some small glue particles in the anterior chamber as well. So this was in a tiny perforation. Too much of glue, the glue went in. So to prevent that, we normally do a paracentesis, put an air bubble in the anterior chamber, so that there is a base to that perforation. And then after drying the epithelium out, scraping off the epithelium around the defect, then you just put a single drop, maximum 1 to 2 drops is required, and it forms a mesh. It dries within a minute. Then you put a bandage contact lens. The glue falls off in about a couple of months' time, and the surface underneath heals very well. So this is one more trick in your armamentarium for healing small defects. Very interesting thing which was discovered again in India in the Shankar Nethralaya in Chennai was something called mucous membrane grafts in lid wiper epithelopathy. Now let me first tell you what is lid wiper epithelopathy, or LWE. In a Stevens-Johnson syndrome, what happens is that there is a keratinization which occurs of the eyelid margin. So the lid margins get keratinized. Now that keratin is very rough and abrasive. Every time the child or the adult blinks their eye, that abrasion, it's like having a stone, multiple stones in the upper lid or the lower lid. So the multiple stones abrade the corneal surface every time they blink. And it's like a windshield wiper. You know, when you're in a rainy season and your windshield wiper moves from one side to the other side, imagine if instead of a smooth wiper, you had a wiper which had got a diamond dust on it. So every time it would scrape the windshield glass, and the windshield glass would undergo multiple cracks because diamond is very tough. So that is called lid wiper epitheliopathy. It scrapes the epithelium off every time and prevents healing. So some bright sparks in Shankar Netralaya thought, can we remove that keratin material and replace it with something smooth? And they decided that the something smooth would be mucous membrane taken from the patient's own mouth. So even in Stevens-Johnson syndrome, where all mucous membranes are involved, the mouth mucous membrane remains quite good. So you can take it from the inner lining of the cheek or from the lower lip itself, LIP lip, and take it off and apply it. I'll show it to you in a small video. So you excise this keratinized conjunctiva, replace it with smooth mucous membrane from the lower lip. It greatly improves the clinical picture and the patient becomes symptom-free. I told you the secondary goals were to make the patients comfortable. So we'll just see a short 1-minute video. This is a patient with both eyes lid margin keratinization, especially of the lower lids. The keratinized portion is excised using Bart Parker knife, cutting both an anterior and posterior portions of the keratinized area, and it is carefully shaved off, taking care that no excess tissue is removed. Exactly the same procedure is done in the other eye as well. A good assistant is required with suction to staunch the bleeding because it's a very vascular tissue. Once this is done, the lower lip is held in a clamp similar to a Calazion clamp, and the marked out portion is excised, taking care to cut outside the marks. The long axis is then split into 2 parts, and 1 part goes to each lower lid. The bleeding is staunched using hydrogen peroxide. The bleeding stops on its own, and then the lower lip can be sutured. Thinned out tissue is then sutured as seen here with 7-0 polygalactin sutures in both the lids. Exactly the same procedure is followed. You can also use glue, but if the patient cannot afford, you can suture on both sides. This is the end of the procedure. Thank you so much for your attention. So the mucous membrane grafting surgery is a very simple procedure, and can be with a little bit of practice can be done by general ophthalmologists also. Just don't get scared of the bleeding. Use hydrogen peroxide to staunch the bleeding. I do a lot of keratoprosthesis work, so that clamp is from my keratoprosthesis, because for my Pintucci keratoprosthesis I take buccal mucosa all the time. So that's a specially designed clamp by Dr. Pintucci, but you can just hold it with artery forceps, the lower lip, and do this. It's you might need to do general anesthesia because you're giving anesthesia to the eye as well as the mouth, or you could give a local at both places. The choice is yours, but it does give the patient a lot of comfort. Moving on to SLET, or simple limbal epithelial transplants. Again, this was pioneered by Dr. Sangwan et al. At LBPI in Hyderabad. No sophisticated labs are required. This is again in chemical burns, but this is in chronic chemical burns. More than 6 months have passed. We used to do take autologous grafts from the other eye in the unilateral chemical burn and apply it to this eye. And we've been doing that for 20-30 years now. But he pioneered the why not use a small piece of tissue, much smaller than what we would do normally from the other eye. And then can we break it up into tiny bits, and somehow can that help in healing? I'll show you the amazing results. So no labs are required. You simply take tiny 2 by 2 millimeter strip of donor limbal tissue. I'll show it to you in a video. Just 1 clock hour is sufficient, which is less than the requirement for autologous transplants from the healthy eye. That's just showing you 1 clock hour in the clock. And then divide that into small 8 to 10 small pieces. As you can see in the picture on the upper right of the screen, the donor limbal tissue is held gently and cut into tiny bits. And those bits are stuck onto the cornea, onto the amniotic membrane, which is, I'll show it to you in a video. So these tiny limbal transplants are distributed evenly with the epithelial side up, as you can see in the pictures and the above. over an amniotic membrane. So first you scrape the epithelium, you put an amniotic membrane with stick it with fibrin glue, then put these tiny bits onto the thing, leaving the visual axis open, stick it more to the periphery, and again stick that with fibrin glue, and then put a bandage contact lens on top. So this is how it is done. You can see that this is the amniotic membrane. The lower part, the amniotic membrane is being just tucked in. And in the lower right, the donor limbal tissue is being cut into tiny bits. So this is a patient with chemical burns who had almost a keloidal tendency. So you can see the amount of keloidal amount of granuloma tissue formed. And this is after 2 times somebody had done an amniotic membrane. And again, still it had got a lot of symblephra and other things. So here I'm doing a slit with amniotic membrane graft. So with this one video, you can see both the things. This is the granuloma being excised. I've opened the conjunctiva all around. It's all stuck everywhere. There are symblephra. This is all unhealthy tissue. There's no limbal. There's complete total 360 degrees limbal stem cell loss. I'm holding the 4 recti muscles because those are vascularized. It's nice to have vascularized tissue to stick things. This is the amniotic membrane being removed from the nitrocellulose paper, and the sticky side goes down. How do we know that? When you touch cotton on the top, the cotton doesn't stick to it. Now I'm going to use fibrin glue here to stick it. So I've put the amniotic membrane, now I've reflected it. I'm putting some fibrin glue there. Then I stuck it back into place. This is the donor from the other eye. The other eye was not involved. So I'm taking the donor tissue. The conjunctiva is not really required. It's more so as I have something to hold on to. And I go about a couple of millimeters into the cornea. This is spare amniotic membrane being used to stick, to close that defect. Now this is the donor tissue which I've removed. I'm cutting it into tiny bits on a wooden board. I like to use this wooden board. And now this coming back to this recipient eye. This is the fibrin glue being used on top of the amniotic membrane which I had stuck earlier with fibrin glue. And I'm sticking those pieces onto the cornea. See, it's well stuck, it's not coming out. Or in the periphery is where we put it. So from one clock hour, you get a lot, and then I put a bandage contact lens on top. And that is the end of the procedure. So see, some of these are, my results are nowhere as good as the original results from LV Prasad. So I'm showing you on the left is the pre-op condition of the eyes. And you see this pre-op A, and you see how gradually this is the stem cells having put simple limbal epithelial transplant here. See how the cornea begins to clear. You can still see these donors over here, and the donors are hardly seen. And you see how crystal clear cornea, which started out from A, can become in E at 6 months post-op. And these are some of their other results. Look at this patient. You would think that this is a lost eye, but clears fairly well. So these are some of the amazing results that they've done. To summarize, it's important to know the basics of how a corneal surface heals. Unless you have imbibed very well what Dr. Samira taught, everything else that I said would be of no use. So you must know how a corneal surface heals naturally. We must be able to eliminate the factors contributing to its non-healing first. To mention some of them, you must see the eyelids, you must look at the blepharitis, and you must see the lacrimal sac, whether it is whether there is a sac abscess or not. These are some of them. You must know whether there is sensations or not. So having done that, having done a proper examination, then there are many tricks that a general ophthalmologist can employ to push a non-healing corneal lesion to heal, as outlined in my talk. If for those who are not in this position, if you're still awake and alert, both Dr. Samira and I will be happy to answer all your questions. Thank you so much for your attention. I'm sorry if I've overloaded your brain. and cause you to remain awake, but do wake up because the question answer session may actually impart knowledge. Thank you.
Thank you so much, sir. It's a wonderful talk and you covered so beautifully. And we have come to know that we have a lot of things on our armamentarium, it may be medical or surgical. Thank you, sir. Thank you. And before we move to the next talk, we got a lot of questions, but we'll be taking in the last. And one or two quick questions. It's from Dilshad Ali. Can glue be used in infected epithelial defect?
Sorry, can glue be used in?
Epithelial defect, infected epithelial defect.
In presence of infection.
In presence of infection, the answer is yes or no. If there is a perforation about to occur, then you can use it. The glue, I'm talking about cyanoacrylate glue. The cyanoacrylate glue can be used. It has a mild antimicrobial effect also. So you can use it only if there is perforation. It's not used as a treatment for infection. Please.
Right, sir. Then we have one question from Dr. Om Prakash. What is the basic pathology in inflammatory keratitis of recurrence? Dr. Samira, would you like to answer?
Yeah. Inflammatory keratitis basically occurs when there is a balance between aqueous and mucus. Normally, aqueous, there is a sufficient amount of aqueous in which mucin floats freely. So if that balance is upset, when aqueous is less, mucus is more, that mucus, it settles down in the lower conjunctival fornix and it joins together forming disulfide bonds. And then when there is loss of aqueous component, the tear film is hyperosmolar. It forms tiny micro abrasions on the cornea with loss of epithelium. And at those sites of epithelial loss, that mucus deposits. And then around that mucus, the epithelium grows around and that forms a filament. So every time the patient blinks, the upper lid pulls upon the filament and it causes extreme pain. So that's the basic pathogenesis. Less aqueous, more mucin, and that mucin deposits on the sites of erosion.
Thank you. I think we should move to next talk because we are short of time also.
Yeah. Dr. Samira, would you introduce the next talk by Vinod?
Yes, Dr. Vinod, who is an eminent refractive surgeon, he's going to tell us about the how to improve healing after surface ablation of cornea.
Thank you so much. Basically, it's a little offside. It's the surface ablation, which is getting very, very popular nowadays. First of all, I would like to be excused for my bad throat. I just recovered from COVID 2 days back. So my voice is not that clear. So I'm sorry for that. Please bear with me. So how does the cornea heal after surface ablation? It's almost same what you've seen earlier. Dr. Samira has told you. Nothing special. Only thing in this, what we are doing in corneal healing, there is a myriad of cytokines, growth factor, and matrix metalloproteases participate in the process of corneal wound healing. Their balance will determine if reepithelialization and stromal remodeling are appropriate. So the final aim is to achieve corneal transparency for restoring corneal function and a proper visual quality. Therefore, wound healing response is critical for a successful refractive surgery. And as for now, the surface ablation has become very, very popular. Earlier, it was called PRK, that got a bad name, but now it has come in a new avatar. Now we call it as advanced surface ablation. And we got a lot of things which has improved our results. So as Dr. Samira has already covered, corneal wound healing occurs. First is the epithelial phase, 12 to 48 hours. I'll not go detail because we already covered it. Second is stromal phase, which may take up to several weeks. Then third is the cross-linking occurs there. That's a natural cross-linking and initial stabilization of the face. The fourth one is remodeling and strengthening of the face, which lasts many months. So after effective surgery, the cornea keeps on healing. It may take few months to stabilize totally. What happens if the epithelium, what we do in surface ablation, we do the de-epithelialization, then we do the laser application. With the combination of these two things, there occur keratocyte apoptosis because this is cytotoxic effect and there is a reduced keratocyte repopulation. So it causes anti-proliferative effect. The keratocyte apoptosis causes migration and proliferation of the surrounding keratocytes. It causes myofibroblasts formation, and these myofibroblasts, they cause a lot of scattering of the light. There is a extracellular matrix remodeling, denser and more disorganized ECM and collagen type, which can lead to fibrotic and hypercellular scar, and that's anterior stroma that is known as haze. So what are the complications we can see in surface ablation and how to avoid them? First is the stromal scarring may be there. That's very common. It was common in earlier PRK. Now we don't see it much. There may be irregular astigmatism. It may be persistent corneal epithelial defect. The cornea may not heal. There is a defect that's lying there in spite of all the medication. Then recurrent epithelial erosion can occur, which may cause significant discomfort. And there may be epitheliopathy. So why the haze occurs? If there our correction is more than 6 diopter, if there is a hyperopic correction that's more than 3.5 diopter, or the ablation depth is more than 80 microns, we are ablating too much, or we are choosing a smaller ablation profile, or there is a retreatment or enhancement, then the chances of complication are more. And if there is a previous corneal surgery, the chances of haze comparatively increases. So the question comes, how we can improve results in advanced surface ablation healing? Dr. Quresh has already covered a lot of things. I'm just going from clinical point of view, not the pathological one. So in preoperative period, we have to do careful preoperative checkup. If there is a blepharitis, we have to ensure there should be good lid hygiene. We have to use a scrub, hot water compression, and antibiotics. It should be taken care, otherwise don't proceed for LASIK surgery. Dry eye has to be treated because the LASIK itself causes some dry eye. If it's there, it will aggravate the condition. So we have to treat first. We have to use artificial tears. We have to use cyclosporin drops. We have to use ointment or punctal plugs that Dr. Quresh has explained to you. And we have to remember that dry eye is common in middle-aged patients. What has been recommended by Dr. McDonald, that tablet prednisolone should be given 30 minutes, that's 80 mg. Normally 80 mg is not available. You can take 40 mg 2 tablets, 30 minutes before the procedure, and it should be tapered daily over 6 days. Of course, I do it differently. I use 80 milligram just for 2 days, not for 6 days. I think it works the same, and there's no need of tapering. Then coming to the operative part, we are using a wooden modulator. MMC has changed the games. That's why the ASA has come back again. It prevents the haze. We know it very well, and it can be safely applied without any side effects. It has been used longer, up to even 1 to 2 minutes, but we haven't found any side effects. Only thing, you have to wash it thoroughly. And one thing is very important, you have to prepare it in a proper way. There should not be no mistakes. It should be MMC 0.02% only. And we have to use a proper fitting contact lens. It is very important because ill-fitting contact lens can damage epithelium. If you see any debris or any tissue or anything lying under the contact lens on second, third day, please change it. Don't wait for 4 days with the same contact lens. Now, there's a pain is there. So there's a one technique described by Dr. Shetty. That is, the contact lens is soaked in aquavit. We got a aquavit units and we put the contact lens in that. We soak it for a few minutes. That's there till the procedure is over. Then we put this contact lens. This aquavit is preservative free and it causes a lot of reduction of pain. The healing is also much better. But again, being a NSAID is a double-edged sword. We have to be very careful while using it. We have to keep a close watch on the patient. Then there are neurocontact lenses which can resolve itself. It's a biological type of tissue. And in 4 or 5 days, it dissolves itself. This provides much better healing, but it's not available commercially as such. We have to be very careful that NSAIDs like naproxen should not be placed directly before putting contact lens. In fact, it should be used after 3-4 days, 2 days. What I use is FLUR or the acufluoride drop. That's a flubiprofen. That's very much safe, and you can put it over contact lens. But don't use Nevanec or Domifen. And these NSAIDs should not be used longer because they can delay the healing and cause epithelial toxicity. Then coming to the post-operative period. avoid overuse of topical anesthetics. It's extremely epithelial toxic. Fortunately, most of the eye surgeons have stopped giving anesthetic post-operatively to the patient. Otherwise, patient can misuse it because they feel pain and they keep on putting it. So please don't give it to the patient. Then oral steroid, I've already told, I use it for 2 days only, no need of tapering. Then strong oral agents, because the pain is there, a lot of pain is there. So we use anti-seizure medication like gabapentin and pregabalin. However, with the newer machines and the newer technology, we see these things are not much required now. The pain is not too much, patient can bear it easily. Then coming to topical cyclosporin, it should be used twice a day, begin immediately post-op and continue for 3 months, whether or not patient have dry eye. It doesn't matter. You have to use in all the patients. Avoid aminoglycosides. They are toxic to cornea. Please don't use them. Then we have to improve the epithelial regeneration. If you find some defect is there, this is person's epithelial defect may be there, then we can give doxycycline 100 milligram twice a day for these defects. If there is a recurrence also, doxycycline is very helpful. You can give it up to 10 days. Normally 5 to 7 days are sufficient. And again, very important is avoid UV exposure. So UV exposure is more common, especially in the beaches or the high hills, but it can happen anytime, even the crowded condition. So patient has to use a 100% UV blocker class. Sometimes what happens, patient buy from the market, it may be written there 100% UV, but it's not there. You use your UV light, check it whether it's blocking it or not. That's because I've seen the patient who have brought the glasses from outside and they were not 100% UV blockers. You have to check it yourself. That's very, very important. Otherwise, it can cause haze in the eyes. Nutritional supplements, a lot of them. Dr. Kulesh has told about the vitamin C as it drops also, but we can use vitamin C orally, omega-3 fatty acids. These are very, very helpful. Vitamin C should be used 1000 milligram per day. Omega-3 fatty acid maybe around 1500 milligram. Then we have got now newer technologies. This is called smart surface technology from Schwind. I'm just giving a brief idea about it. And this is a streamlight from Alcon. You see, our limit has now gone up to 10 diopter. Even people are treating up to 12 diopter. Earlier, it was limited to 3 or 4 diopter only. Now, with this better profile, we are using much higher range for not only myopia, for hyperopia, for cylindrical collection, and for mixed astigmatism as well as. This is a streamlight from Alcon. The advantage is that is a one step. There's no time lag. It takes out the epithelium also. It does the correction in same sitting in a one step. There's no time lag and it's a one process only. So first the epithelium is removed, then the refractive correction is done. Optical zone selection itself is does. Then less myopic shift compared to standard PTK mode because of optimized epithelial surface and uniform removal. So what is the advantage there? This newer machines from Schwind Alcon, they remove epithelium in a much better way. That's a uniform removal of the epithelium. Unlike what we use in PTK or we just scrap or we do other things, there's not a clear removal. And there is a very clear zone outside the healthy epithelium is there. So healing is much, much better. And because of this profile, the epithelium grows very smoothly. And even on second or third day, you can see the epithelium has covered the surface. So just brief about it. Streamlight utilizes to optimize epithelial ablation. More pulses are used outside the 4 millimeter jaw zone to prevent epithelial remnants. That is what is the principle of wavefront optimized treatment. Then Streamlight is one-step treatment requiring only one centering, therefore enhancing the precision. There is active eye tracker throughout the entire process. So epithelium ablation zone automatically determined by the laser and based on the PRK profile. Suppose we are ablating around 6 millimeter, the epithelium will be removed around 7 millimeter. That's very, very precise. And it helps in good epithelial recovery. There is active eye tracking throughout the entire process. So advantage is trans epithelium PRK is that accelerated healing is there and visual recovery is good by limiting minimum epithelial removal. There's less pain. There's reduced risk of haze in these cases. Because of the accelerated healing, there is a smooth surface and better contour. By removing damaged cells and reducing thermal effect, we got a much less risk of haze. So the shortcoming at present is, the flip side is that it accentuates the importance of epithelial mapping. We have to know how thick is the epithelium. It may vary from patient to patient. So we have to have a proper surgical planning. And it's still not available with premium profiles. Suppose we want to do customized treatment with this process, it's not available. Then we have to go to standard advanced circulation. We can't do with this one. Suppose we want to do custom Q or we want to have topography guided treatment, then we have to use those profile patterns. And there is a price tag, company are charging for it. But it's a gentle, no touch, no cut, no incision, there's no flap. This is safe because more biomechanical preservation and corneal stability is there. We are just taking a top surface only. Stress-free, faster treatment in a single step, no effect on posterior segment. So where there's the corneal, where is the pathology in the retina, suppose RD or something there, it's not going to affect because we're not putting pressure on the cornea. Unlike what we do in SMILE or what we do in femtolasic or what we do in SPK. We are not putting any pressure on the cornea. So much safe in these conditions. At least it is not aggravating those conditions. And there is excellent outcome. It can be combined with CXL and economical for you. We don't require femto or laser again for this or SPK machine. So just to conclude, surface ablation is one of the most effective tools in surgical armamentarium of refractive surgeon. It is still underutilized, but it's very promising and exciting with superior results. Thank you. Thanks a lot.
Thanks very much, Dr. Vinod. Very informative. It's something new for me. Thanks a lot.
Right. So we've got a few questions also, I think.
Yeah, I have the questions now.
Dr. Faiza Rashid, she wants to know, please explain Dua's layer again.
Dua's layer, previously it was thought that just under the stroma, there is the Descemet's membrane. But Dua's layer is the aggregation of very fine collagen fibrils at the end of stroma and before the Descemet's membrane. So it's just between, and it's used basically by the refractive surgeon, by the corneal surgeons for endothelial, when they do the to replace the endothelium.
Even for DALK, Samira, we are using it. Yeah. So what happens is that the Dua's layer, when we form a big bubble, when we are doing DALK surgery or deep anterior lamellar keratoplasty, we were forming a bubble. We didn't know where the bubble was going earlier. We thought it was separating the Descemet's membrane from the rest of the cornea. But actually, the bubble is going between Dua's layer. Dua's layer is very, very tightly attached to the Descemet's membrane. So the bubble, when we put it, it's going between Dua's layer and the rest of the stroma. So when we do a deep anterior lamellar keratoplasty or DALK, we are now replacing everything except the deepest layer of the stroma. So we have a safety margin already. So it's being used also for the posterior keratoplasties. That means the PDEC, what we call the posterior Descemet's endothelial keratoplasty, where Dr. Amar Agarwal and others use the Descemet's with the Dua's layer as a replacement for the inner lining. So we can use one corneal tissue for doing a DALK, and the remaining tissue can be used for a PDEC. Two corneas in the same of a donor can be used for, one cornea of a donor can be used for two patients.
There is one question from Dr. Wakar Ali. If there is a number spherical -14 with -3.65 cylinder, 170 axis, then PRK is better to use or the phaco is the best choice? So
you can answer that.
Yeah, I'm going to answer that. Dr. Wakar, phaco is not a choice at all. Of course, PRK is not a choice in these cases, surface ablation, because the limit of surface ablation is around 10 to 12 diopter. We have not done higher than this. I think ICL is the best option. A patient is fit, you have to measure, and it's with high number, ICL is the best option. I don't recommend phaco for young patients who are myopic, and with this high number, they are certainly going to have some retinal problem also. So please don't do cataract surgery or clear lens extraction in this patient, unless the patient is very old, say around 45 or 50, then you can think of the phaco. But in young patient, there's a strict no. If you can't find anything, suppose he's not fit for even ICL, you can do a LASIK or surface ablation and reduce the number. If you think the cornea is not proper thick, I would say cornea is around 530 or 520. So it's not possible to do -14 correction. So it's better to do undercorrect. A -14 patient is brought down to -4, feels much elated, much comfortable. They don't want to 0, they are tired of thick glasses. So that's again an option, but phaco is no choice in these cases. And ICL probably is the best. I think most of the questions already answered. You on the list. How to prevent corneal keloid formation after pterygium surgery in a patient who may be prone to keloid formation? Is a question by Dr. Farooq.
Yeah, I did answer it in the chat saying that don't do pterygium surgery unless you're proficient in doing a conjunctival autograft. So you must put a conjunctival autograft to cover the bare sclera. You can stick that conjunctival autograft by using the patient's own blood, that is autologous blood, or you can use fibrin glue, or you can take sutures. There's nothing wrong with that. And if you smoothen it out well and see that there is no excess tissue and no inclusion cyst, the chances of keloid will be reduced. However, there is a small percentage of people who will still develop because they have a keloidal tendency, as you rightly said. So you need to warn the patient that he may still develop something like this.
Then there is a question from Dr. Shahid Hamid. Role of tetracycline in chemical burn.
A big role because the tetracyclines and doxycycline, the role we give it for almost every patient of chemical burns, and you can give it for up to 3 to 6 months at a stretch. It's the same even in meibomitis and in patients with meibomian gland disease where we give the doxycycline. So doxycycline is not given, or tetracyclines are not given for the antibiotic effect, but for the side effect, the other effects that they have on matrix metalloproteases, on lipases. So because of these, they promote healing, and that is the side effect of the antibiotic which is given. So sometimes I've had my patients, when I write, get continue doxycycline for 3 months, and the pharmacist says, your doctor made a mistake, he writes too fast. These doctors don't know anything. You know, it's an antibiotic, you can't use it for more than 3 days, not 3 months. He must have written months by mistake. So they stop after 3 days. So now I start telling patients, please don't listen to the pharmacist, listen to what I'm telling you.
Right, sir.
Yeah, can I add? It's anti-angiogenic as well. It reduces vascularization. It's antibacterial for all these low virulence organisms. It's excellent, and it promotes corneal healing. It promotes tear film stability. So in all patients with poor healing for dry eyes, tetracyclines is a must.
Yeah.
I think doxy,
topical as well as oral.
Doxy again, I think works on the same principle, and in even COVID patients, it's being used now. So there's one question from Dr. Saima. Can blood drops be used in non-healing ulcers other than chemical injuries?
Yes, it can. It can. We've used it in neurotrophic keratitis as well with remarkably good results. And you can bleed the patient again after 3 months. So I typically would not bleed the patient more than 4 times in a year. But in patients with, I've used it for Steven Johnson patients with persistent epithelial defects, and I've used it up to 4 times in a year, and gradually they do come back to normal. So these are difficult cases, but yes, you can. Important thing is to prevent infection in that autologous serum. So you need to store it in a refrigerator. Unless the patient has got refrigerator with them at home, you don't prescribe this. So they keep the vials, because we make multiple vials. They put it in the super fridge, and the only one vial is kept in the lower fridge compartment at 4 degrees. The others are kept at minus temperature, and that one vial is used for a week maximum, then thrown away, and a new one is taken. So we typically prepare 4 to 5 vials at a time, so it lasts them for about 4 to 6 weeks.
Right.
But there is this one problem with this full blood or 100% serum is that it's got high content of vascular endothelial growth factor, VEGF. So if we're giving whole blood, then it will increase corneal vascularization. So that is why we give diluted.
Correct. I've never used 100% autologous serum.
No, you can say whole
20%.
blood as well, no? Whole blood.
No, whole blood is different. That is, I form a blood clot on the cornea at night and it disappears. It's not as a permanent treatment. So for about 3 to 4 days in an acute chemical burns, that is the time. Just for about 3 to 4 days maximum, I would put the blood clot at night. And the subconjunctival blood is also only in an acute burn for about the first 1 week or 10 days. It's not as a continuous treatment.
Not continue. Okay.
No.
Okay.
Only serum drops is continuous treatment.
The clot provides a coverage of raw surface.
Yeah.
So, and there's one question for Dr. Quresh from Dr. Khalid. What is your preferred choice for tarso, surgical or glue? How do you deal with discomfort in glue tarsography?
My preferred choice is surgical. 100% I would go for surgical tarsography. There are some the patients who are a little extra sophisticated and don't want this surgical process. In them, then I would recommend a Botox into the lid for a temporary tarsography or a cyanoacrylate to just pinch the lids together. But otherwise, surgical 100%.
Normally, you do the lateral 1/3 or the central part?
Lateral 1/3 to lateral half sometimes.
What is the function of glycoslavex by Dr. Kamran? I think.
Function of glycocalyx?
Yeah, glycoslavex. Probably is not written properly.
Samira, have you followed the question?
No.
No.
I don't know what he's asking.
Glycoslavex, I think there must be some spelling problem.
Yeah. So I think that's the green line that Dr. Samira was referring to. Samira, in the diagram that you showed, that green line around the epithelium, the pseudopodal microvilli.
Yeah. Mucin glycocalyx layer.
I think that's what she's referring to.
So what about it?
What's the function?
What is the function?
What's the function? Without that, glycocalyx is secreted by the surface epithelial cells, corneal surface epithelial cell. And to that, the mucin binds. So this negatively charged glycocalyx, positively charged mucin molecule, that forms a blanket over the whole corneal epithelium, over which the aqueous component of the tear film can then stabilize. Without this mucin glycocalyx layer, the cornea is water repellent, hydrophobic. The tear film will not stay over it. It will not wet it.
If you think of a skyscraper, this is the foundation. And on the foundation, unless the foundation is strong, you can't build multiple floors of the skyscraper.
You're right.
So similarly, you need the binding there of the mucin. Only on top of that will the aqueous layer sit.
Right. There's one more question. What is the role of Dua's layer?
We are discovering that more and more. Before Dr. Dua discovered it, nobody knew it was there. Now we are using it surgically. It's very helpful to us, as I said, to differentiate. And we are understanding more and more about the behavior of the cornea and why certain corneas perforate and certain corneas don't perforate. What happens in a hydrops in keratoconus? So the Dua's layer remains over there. Why is there when there is a desmetocele? As Dr. Samira showed a couple of lovely pictures of desmetoceles. So those desmetocele is not the decimase. We call it desmetocele, but there is actually a Dua's layer on top of the decimase because the decimase is very thin. It would have perforated. But because Dua's layer is a fairly tough layer, it prevents the perforation. So I think nature has designed it as an additional protection for the decimase.
Right. So there's one question for me. There's the importance of Sharma test before going to do LASIK or any other surface ablation procedure by Dr. Shahid. Basically, we have to evaluate doing before any surgery because we know the surface, optical surface is very, very important and it's maintained by the wet layer. So if there is any deficiency in the aqueous layer, lipid layer or mucin layer, it's going to cause a lot of discomfort. Plus the quality of vision may not be very good. Secondly, any procedure, once we are touching the cornea, it may be surface ablation, it may be femto, it may be SPK. We are going to damage corneal nerves, which may take up to 6 months to heal. And certainly LASIK is going to little bit aggravate the condition. If it's already dry is there, it's going to increase that condition. And we have to treat the dry eye first. with all means we have described in my presentation. So we have to treat the dry eye first. If we can't treat the dry eye, suppose patient is not responding to our treatment, then please don't do any refractive surgery in these patients. They will be the most unsatisfied patient because there will be a lot of higher order aberrations in these patients because the surface is not popular and they will not be a very happy patients. So better to avoid
whether to use Shermer's test or to use any other test, it depends on you. You can use your clinical acumen, a good slit lamp examination, the lower tear film meniscus, if you're good at seeing, just by a glance, you'll know whether there is aqueous deficiency or not. So it depends. Then we have got sophisticated machines called SBMs and which give you mammographies and all sorts of equipment is available also for dry. What Dr. Vinod Arora is saying is very correct, that for any surgery that you undertake, please have a look at the eyelids and the eye clinically and look for dry eye. Whether it's cataract surgery, pterygium surgery, the refractive surgery, doesn't matter. You need to see for yourself. And if in doubt, you can use a Shermer's, you can use so many other tests which you have at your disposal.
You can have backup time also. That's very easy.
That's why the multiple tests are available.
Yes, sir.
So there's a question about lag ophthalmos and what is the treatment? Yes. Well, there are a few people when they sleep, the eyes are a little bit open because the upper lids, they don't close upon the lower lid like a zipper. And a little bit of cornea inferiorly is exposed whole night, and that causes punctate epithelial erosions and chronic dry eye, or even recurrent corneal erosion. So treatment is to lift up the lower lid and stitch it higher up on the lateral orbital rim. It's called the lateral tarsal strip procedure. So the lower eyelid is higher, and so the upper lid will come down, or you can relax the levator a little bit.
Yeah, we sometimes use gold weights in the upper lid as well. The important thing is to be aware that when you see the funny punctate stains in the lower 1/3 of the cornea, you must have a high index of suspicion that this patient could be having a little lid laxity or an open eyes at night. And you need to, if the patient is married, talk to the spouse and find out whether it happens, because the patient will be unaware. And if it's a child, then talk to the parents and ask them to observe. Sometimes my parents have told me, sir, we have never looked. So I said, tomorrow night, please go and look, or for the next 1 week, please see your child when he's sleeping. If possible, take pictures and show me. And we discovered that there is a little open area at night. So be aware that when you see punctate staining and you can't explain this, look for this, and then you'll be able to treat this. You can even just use ointments at night for some time.
And there's one question from
yes.
There's one question from Dr. Tanuja. Is it okay to use oxytetracycline ointment instead of tetracycline, oral tetracyclines?
Oral tetracycline has its own role. You need not use oral tetracycline. In India, we're using more of doxycycline. Oral tetracycline stains the teeth a little more than those side effects are there. So we prefer oral doxycycline. You can also use azithromycin, but azithromycin can't be given over long term. So if you want, you can start with azithromycin for 3 days and then go on to doxycycline or tetracycline. But the topical tetracycline doesn't have the same effect as the oral. So there is a place for both.
All right. So there's one question. Where it is? Yeah, from again, Dr. Tanuja. One of my patient had 2.75 cylindrical at 180 degree in one eye. I corrected 2.5, 180 degree, but it ended up with minus 190 degree. What should I do, Dr. Vinod? The problem is that in cylindrical number, sometimes with topography, we don't get a exact exact vector of the topography. Either we have to take a tomography in these patients also. And this, you're showing that -1 at 90 degree, that means a little bit of overcorrection you have achieved. And there is a coupling effect in it. So most of the softwares available in the LASIK machines, they already take care of it. But you have to do a thorough examination again, look for the topography and tomography both, and see where the exact axis is. Sometimes the auto-ref axis, what you get or what you get in topo is different. So if you want to know the exact axis of your patient, then look carefully at the topography and divide it into two parts. You may seeing a dumbbell shape on your topography. Just put a paper or a scale or anywhere and try to divide it into two parts. It's not easy to explain you, but suppose it's like a dumbbell shaped presence is there, most of the topographies, and divide it, actually put a paper or anything there, and you see a line straight dividing the two hemispheres. This line gives you the exact axis. So if you are in doubt, please repeat your all test. If you're getting the same readings on both machines, then it's okay. But if you're getting different readings, you have to look for the lubrication first. That's again very important. And you have to verify your machines again and again. Otherwise,
just to add, Dr. Vinod, just to add, don't jump in to do anything surgically or to do another procedure till you've taken at least 3 readings, one month apart, and you find that the cylinder is stable, because it could be still changing. And 3 months down the line, it may be different from, you've got a margin of 1 year before which you can do an enhancement procedure. So don't jump in to do an enhancement just because patient is dissatisfied. Tell them in many cases it will correct itself. So I wait for minimum 6 months before any enhancement. Dr. Vinod, what about you?
Yeah, agree on that, because cylindrical lumbar is a dynamic process. It's not a very stable, and it keeps on changing. You must be seeing many of the patients you are giving refraction. Over the years, the refraction changes. It's not the spherical, the cylindrical number, which keep on changing the axis. So it depends on various factors. Once it is stabilized, you have to give it sufficient time. And you see the readings are coming, just Dr. Kuresh has explained, it maybe after 6 months, you have to see whether if it's still there, then you would think of the retreatment. Sometimes it has come down itself.
So there's a question from Dr. Faiza. In corneal ulcer treatment, at what stage should we start vitamin C and doxycycline? I think immediately it's going to be, it will help the patient and improve the tear film, improve the growth factors. So straight away, I think.
Then probably is the last question, I think. It's from Dr. Geography. Dr. Jaffrey, can we get certificate of attending? Dr. Samira?
This was just a personal effort. I don't belong to any institution or anything. This was just to educate my group, which we teach online for the last so many years. So that certificate won't mean much.
You can get a certificate from Dr. Samira, but it will not add to CME. It's for your personal use. It's about learning so many things. I think that's the answer. Any questions more?
I think we've done
all the questions.
Yeah. I think yes.
Dr. Kuresh, what are the nutrients we can give, like vitamin C you told? What other nutrients are helpful in these? As any role of vitamin A or omega-3 fatty acid or?
Okay, omega-3 fatty acids was used quite a bit till a study came out called the DREAM study, DREAM. The DREAM study came out and showed that omega-3 fatty acids are no good, are not better than placebo in treating patients of dry eye. But I have analyzed the DREAM study tremendously, and I'm still giving omega-3 fatty acids to our patients. A is that we are not doing any harm. B is that omega-3 fatty acids have proved good effects in the whole body, including the heart and other things. So we are not doing anything wrong in giving omega-3. There is no such thing as too much of omega-3 fatty acids. Number 4 is that at least in India, the source of the omega-3 fatty acids from which they are manufactured is different from that which is manufactured in the US. So it could be, there could be a lot of variables in this. And 5 is we are seeing anecdotally good results with omega-3, which is used as a supplement. It's not used as a sole therapy.
And then
the other one you mentioned
is
vitamin D.
Yes.
Yeah, vitamin E, vitamin D as well. Vitamin D is now being increasingly touted. B12 and D for corneal nerves and corneal healing. So I would give vitamin D to any non-healing patient as well.
And vitamin C and vitamin A as well. So
true,
all these.
I think
yes.
Everything which is good for body is good for eyes.
I think so.
Absolutely.
At least we've done the first 5 letters of the alphabet. A, B, C, D, E.
Yeah, all of them.
Again,
So-
I'm in a healthy body. So if forget vitamins, but basic nutrition in it. You see, some of our patients come from very poor strata of society,
Yes.
and they don't have 2 meals a day. And such patients, patients getting corneal ulcers, if you just treat the ulcer, it's not going to help. So you must take out money from your pocket, give it to them, see to it that they have at least for the next 15 days, they have a good, healthy meal. Talk to them about diet a little bit. Very rarely you have to do this. So it's not a big dent on the pocket, but don't ever treat the eye without looking at the patient as a whole. Some people have a patient walks in, an assistant has taken history, that history has come on an EMR on their computer, everything fancy. They've read the history, patient doesn't have to open his mouth, he's put straight on the slit lamp and examined. So you miss so much. You miss seeing the state of his clothes, whether he's wearing shoes, chappals, not so that you can charge more that he's wearing shoes. And that's not right. But the other side of the story, that if he's barefoot, he can't afford footwear, what is he going to expect? And then take out medicine from your samples. I ask for samples from pharma companies. Many people don't do that. Give it to them. You can write expensive eye drops. They're not going to buy it because they can't afford it. Tomorrow they will, out of shame, not come back to you with the treatment because they couldn't afford 100 rupees for the corneal ulcer treatment. So take out the medicine from your cabinet. You're not losing anything. Sorry, I just went ahead. This is beyond the topic. Sorry. It's something I think that Samira also feels strongly about. So,
No,
Oh, yeah.
basically, we have all
Totally.
set of patients from very poor to rich.
you must consider all types. Yeah.
Yes. We have to look for the economic condition before prescribing medicine.
Shall I think we should wrap up 2 hours.
Thank you.
Right.
Thank you, Dr. Samira, for inviting us. It's been a pleasure to have been part of your talk show session, and I'm sure the audience has also enjoyed the lectures. Thank you.
Yeah, thank you very much, everyone, for coming and being patiently listening to us for 2 hours. And thank you, Dr. Kuresh, Dr. Vinod. It was lovely to have you.
Thank you
Hopefully
so
we'll
much.
do something
Thank you
again.
so much. We
Okay,
really enjoyed
bye-bye.
the talks.
Thank you.
Okay, thank
And
you.
it's very interactive. A lot of questions from the. I think still the questions are coming. I think you can direct to Dr. Samira, Dr. Kuresh, or
We
to
can
me,
send them to the group now.
Yeah.
where we can be answered.
More
Yes.
questions on the group, I'll
I think
answer.
it will not end.
We'll be happy to. We don't want to leave any question unanswered. Yeah.
Yes.
Okay, bye.
Thank you. Bye-bye.
Thank you.
Thank
Thank you so much.
Bye-bye.
Bye.
Thanks, Dr. Vinod.
Thank you
Bye-bye.
so much.
Thank you all.